I think we should switch to English because this is an international course. So this course is about vertebral osteomyelitis. My name is Marcel Ivanov. I'm a neurosurgeon from Sheffield. And this short presentation is about infections, spinal infections. We would not discuss treatment. That will be a separate topic. And by the end of this lecture, you should become familiar with the etiology and pathogenesis of osteomyelitis. You will learn the symptoms of osteomyelitis as well as the clinical, radiology and lab diagnostic criteria used in establishing the diagnosis of vertebral osteomyelitis. Now, what is osteomyelitis? Osteomyelitis is a progressive infection of bone and or bone marrow and surrounding soft tissue, usually caused by pyogenic bacteria. Now, if we were to look at classification of spinal infection generally, you will see that you can have spinal abscess, you can have discitis, spondylitis, as well as paraspinal infection. But today we'll focus on discitis and spondylitis, so infection of the disc and vertebrae. Now, few general words. The incidence of spinal infection increased significantly in the last decades, and it is varying between 1 to 20 to up to 1 to 100,000 persons. The vertebral osteomyelitis, it represents approximately 2 up to 7% of all cases of osteomyelitis, and it is more common in males. And what you should remember that there are two peaks of infection. One is below the age of 20, and the second peak is in a group of 50 to 70. Another thing which is important to remember, those younger patients, in their cases, the infection is frequently associated with intravenous drug abuse and HIV, so immunodeficiency syndrome. If you look at distribution per spinal segment, you will see that the C-spine, in cervical spine, the infection is only 11%, and it is not so frequent, and the most frequent one is in the lumbar spine, which represents approximately 58% of cases. Now, what is causing infection in spine? Theoretically, any condition that causes bacteremia may lead to vertebral osteomyelitis. And the most common is pyogenic infection. We use the term pyogenic restrictively to refer to bacterial infection that produce predominantly neutrophilic infiltrate and purulence. Now, although mycobacteria and certain fungal infection can produce purulence, this is a lymphocyte predominant immune response, and it is cold pass. Yeah, so the clinical behavior and management of this infection differ enough from that pyogenic, and that's why it should be discussed separately. Now, Staphylococcus aureus is the most common agent. Depending on the study, but something between 30 and 80% of all infections, they are caused by Staphylococcus aureus. So this is something which is important to know if you are not clear about this cause of infection, because it may influence your initial treatment. The other frequent pathogens are Coagulase negative staphylococci and several species of streptococci. Likewise, Escherichia coli frequently causes spondylitis and spondylodiscitis. The anaerobic bacteria is unusual, so generally it is associated with foreign bodies, stabbed wounds and so on. Fungal causes of spondylodiscitis are very rare, and they particularly includes Aspergillus or Candida infection or Cryptococcus neoformans. Again, it is important to remember that in 8% of cases, the patients may have multiple organisms responsible for infection. So if you isolate one organism and you know the antibiogram and antibiotic which is working but the patient is not responding well, one of the potential reasons is that this patient may have a second bug which is responsible for infection, which may require a different antibiotic. Now, if we look at the risk factor of infections, we may have surgical factors which we can influence as surgeons, and we may have non-surgical risk factors. So non-surgical risk factors obviously is advanced patient age, obesity, poor nutritional status, diabetes is a well-recognized risk factor, chronic infection, especially HIV, viral infection, substance abuse, and so on. You can see the list here. So it's very difficult. We as surgeons, we usually cannot change them, at least immediately, but there are some surgical factors which may influence the infection. So if we do some spinal surgery, so long duration of surgery is a potential risk of infection. If there is any significant blood loss, again, a surgical segment or number of surgeries, all this may have impact on the risk of spinal infection. The spinal infection usually comes from another source. Yeah, so it doesn't originate in spine. It usually seeds in spine coming from elsewhere. And if we look at the primary sources, the most common source is usually genitourinary tract infection. But we may have also infection coming from the respiratory tract infections. But again, in approximately third of patients, the source of infection cannot be identified. The infective organisms can be carried to the spine by 4 main routes. Yeah, so via the arterial blood supply, retrograde by the vertebral venous plexus, or by direct inoculation, kind of contaminated surgical instruments, or a needle or a penetrating injury, or by extension to the spine from some adjacent nidus of infection. For example, if somebody has a pulmonary abscess, then infection can spread into the spine, just going into the vicinity. Or similarly, if patient is paraplegic, has some sacral pressure sore which is getting infected, it may spread into the spine as well, and it may be very difficult to treat. The arterial spread is thought to be the most frequent route of bacterial seeding, which explains the typical location and progression of vertebral osteomyelitis. Wiley and Trueta demonstrated that the rich arterial anastomosis within the vertebral body with end arterioles and metaphyseal region, they demonstrated how bacteria could easily spread hematogeneously to the metaphyseal region of the adjacent vertebra. So remember, this is an histological image from 1959, so it's been 60 years now, and it is beautifully demonstrating how the bug is reaching the spine. In adult patients, bacteria cannot reach the disc directly because of the lack of blood supply, but for the same reason, the bacteria are extremely prone to colonization. And once bacteria seeds the subchondral bone adjacent to the vertebral end plate, the bacteria can directly invade the disc, causing what is usually first visible radiological sign of infection, discitis. Yeah, so untreated discitis can evolve to spondylodiscitis, affecting the adjacent vertebral bodies with associated bony destruction, abscess formation, or both. It has been suggested that Batson plexus may also be a route of hematogenous spread of infection. So Batson, in this paper, demonstrated in injection studies that dye, or the contrast, flows into the valveless vertebral venous plexus when the pressure is applied to the lower abdominal wall. So Wiley and Trueta actually demonstrated that it takes quite considerable force, quite considerable pressure to fill these small metaphyseal vessels in a retrograde fashion compared with the ease of injection of the metaphyseal arterioles. Yeah, so this is suggesting that the most likely cause of infection is actually arterial and not venous. Another question we have to answer is why and how the patients develop neurological deficit. There are potentially few mechanisms. Yeah, so you may have direct compression of the spinal cord or neural nerve roots by the epidural pus. Yeah, so the pus may compress on the spinal cord, which may cause neurological deficit. It could be a granulose tissue, which is also increasing in size and compressing the neural tissue, or the infection can destroy the bone, and the fragments of the bone can dislodge and cause some compression on the spinal cord. At the same time, there may not be direct compression, but because of the infection, spine is getting unstable on a specific level. So this instability may cause some additional bruise to the spinal cord and be responsible for the neurological deficit. Another important factor which we should not forget is the neurological deficit secondary to microthrombosis of the small vessels around the spinal cord. So when you have infections, these vessels getting thrombosed, spinal cord is suffering because of the ischemia, and that's why they may have a deficit. And Usually, it is a combination of factors, so we will need to address them all. As spinal surgeons, we'll need to address all. If there is a compression, we need to decompress. If there is any instability, we need to stabilize the spine. If there is any bone formation, we need to kind of realign the spine without causing any new bruise to the spinal cord. And at the same time, we need to look at the general factors responsible for this. How do we establish the diagnosis? Obviously, the diagnosis is generally difficult, at least in initial stages, and requires a high level of suspicion. This diagnosis should be supported by clinical, by lab, and imaging findings, like any infection. Clinically, what the patients with infection have, initially, they may have some general manifestation of infection, and this manifestation very much depends on the virulence of the organism, but also on the resistance of the host. So at presentation, the presentation can be different. It could be acute presentation in aggressive infection, it could be subacute or even chronic. So it's very important to take complete history. Remember, not the imaging, it is the history and clinical examination which is the first kind of indications of spinal infection. From symptomatic point of view, the most reported symptom obviously is pain, and at the beginning this is usually not severe. It may be quite diffuse without any focal location. In a healthy patient, the pain is often poorly localized, and for this reason it is not uncommon for pain to be present for several weeks or even months before the diagnosis of osteomyelitis is established. Again, on examination, you should also look for kyphosis. If infection destroyed the spine, the bone, patient may develop deformity. There could be some swelling or some other visible source of infections. Again, you need to look for some primary source of infection. So if there is some ulcer in the leg or dental infection, you need to recognize this, which again will guide you through the potential primary cause of infection. From lab point of view, obviously we'll look for general inflammatory markers. The erythrocyte sedimentation rate, as you all should know. The most important, I think, is the CRP, the C-reactive protein, which if it is raised, it is a clear sign that this patient is likely to have an infection. And again, CRP is not good only for establishing the diagnosis, but checking regularly CRP, maybe twice a week, can help you with a response whether your treatment is good in a specific case. Obviously, when you do the diagnosis, you want to isolate the bugs, so taking blood cultures, and it is important to remember you should take the blood cultures before you start the patient on antibiotics. So this is one of the most important things, to isolate the bug and to identify the antibiotic which is efficient in this specific infection. Now, CRP, the C-reactive protein, is good, but we can also measure the procalcitonin, and it can be also helpful to guide you with regard to establishing the diagnosis of infection. Imaging is important. Imaging studies are important for establishing the diagnosis of osteomyelitis and essential in guiding the treatment. X-ray, if we start with the X-ray, the specificity of native X-ray in the diagnosis of spondylolischitis is quite low. It is approximately 59% and can at most detect irregularities of vertebral end plates or low intervertebral disc height, or in advanced cases maybe you will see some bone erosion or deformity of the spine. MRI, magnetic resonance imaging, remains the most reliable method to diagnose spondylolischitis, and this is because it has very high sensitivity, so 96% of cases will be identified with MRI scan, and very high specificity, so up to 94%. And capability to provide very detailed data on paraspinal tissue, so you can see not just infection, you can see how this is affecting the spinal cord, the neural nerve roots, the disc and soft tissue around. So this is very helpful examination. What you're looking on the MRI scan, obviously you will see some edema, you may see some enhancement if you give contrast, you may see the separate collection, pus or granulation tissue, you may see some bone destruction. So on T2, this will be usually hyper intense signal. On T1, it will be hyper intense signal. So that's something which you will need to learn when you're looking at the imaging. MRI scan is helpful to not only to diagnose the infection, but also to assess the response to treatment. But again, you should remember that usually there is some delay between the clinical response and MRI findings. So sometimes you may still see some significant changes on the MRI scan, but if the inflammatory markers are improving, if the patient is doing well, then that's a good sign that infection is responding well to treatment. It may take 3-6 weeks to see some changes on the CT scan. Yeah, so CT also is helpful, but usually it will be helpful in late stages. It may show you some bone destruction, deformity, but it can also help with planning the surgery. Again, we should not forget the role of CT when we do the biopsy. If you still don't know what is the bug, we can do a CT guided biopsy of the discitis, which will usually help to isolate the bug. Again, this is important to do before we start on antibiotics, because once you start the antibiotics, the result may be negative already. Another helpful option is bone scan. I will not insist on this one, but the options we have would be 67 gallium SPECT scan or fluoro-2-desoxy D-glucose PET scan, which may be a promising technique for distinction and differentiating between the degenerative changes, which also may look abnormal, or fractures and infection. Now, if you compare PET and MRI scan, MRI is the modality of choice to diagnose epidural and spinal abscess with a sensitivity of 93%. So it is a high sensitivity. PET shows higher sensitivity in diagnosing paravertebral and psoas abscess, and usually it is more sensitive in the early stages. So if you look at this paper, this is just one of the papers comparing PET CT and MRI scan. It shows that PET is more sensitive in the first couple of weeks comparing to the MRI scan. PET scan is not universally available, and MRI scan still remains the gold standard in examination or assessment of the infection. Now, PET scan can be helpful in specific cases, in particular if patient had some surgery and there is some metal work in the spine. If you do the MRI scan, it will give some significant artifact. With the PET scan, it is much easier to identify any hot spots, which will be a sign of infection at the level of instrumentation, otherwise not possible to identify on the MRI scan. There is no pathognomonic finding on the MRI scan. So it is usually a combination of factors. It's a clinical picture, it's a sepsis, it is a pain, and MRI findings. This is what is establishing the diagnosis. And there are several algorithms available in the literature. I wouldn't insist on this. I would strongly recommend to look into the literature. These are two good papers which I would suggest to read. One is a paper published in Acta Neurochirurgica just a few years ago, Management of Spinal Infections. It's a general review of the literature. So it's a very nice summary. And the other one is a paper by Vaccaro, which was published in European Spine Journal. I will highly recommend you to read this one after this course. Now, in summary, vertebral osteomyelitis is a serious condition. The incidence is increasing, and the early diagnosis is of paramount importance. As I said, it may take up to 6-8 weeks until this is diagnosed, because people just feel that this is a back pain and often ignore it. So you have to have a degree of paranoia to suspect that there is infection, especially in patients with risk factors, with diabetes, obese patients, and so on. MRI scan is a golden standard imaging for confirming vertebral osteomyelitis, but PET scan can be helpful in specific cases, especially when patient had some instrumentation, or in early stages, first 2 weeks, the PET is much more sensible than the MRI scan. Of course, it is impossible in 15-20 minutes to teach everything about spinal infection. As you could see, for those of you who would like to deepen the knowledge about the spine, we are organizing a very nice course with a fantastic faculty coming from States, from Canada, and from Austria. if you're interested in spine, that will be an amazing course to expand your knowledge. We'll have some first part, which is a hybrid one, done online, and then we'll have hands-on part happening in 4 simultaneous places in the UK, where you'll learn how to place screws, how to identify entry points at very, very basic level. So hopefully the travel will be possible at the time. You're very welcome to join if you wish. Once again, I wish you all the best. Hope to see you again live.